Yang Berhormat YB Lukanisman Awang Sauni, the Deputy Minister at the Ministry of Health. Yang Berusaha Encik Jegathes Waren, the Country Public Affairs Head at Novartis. Esteemed presenters, panelists, experts, practitioners, colleagues, and friends. Welcome to the launch of the breast cancer care in Malaysia, access to early detection and optimal treatment. Friends, to those who are new to IDEA's work, at IDEA's, our work programs are divided into 4 different units: the Democracy and Governance Unit, the Public Finance Unit, the Economics and Business Unit, as well as the Social Policy Unit. This project is one of the projects under our work stream in the Social Policy Unit under the Access to Healthcare program. In the past, we have worked on various issues, including on the theme of rare diseases. Under the same unit now, the team works in the theme of access to education, linking to different stakeholders like the Orang Asli communities, refugees, as well as asylum seekers. This year, our work will continue in implementing micro-solution projects to targeted Orang Asli schools in selected areas within Malaysia. I'm so proud of the team with the support of our partner Novartis and other stakeholders on the ground. We are very happy to be launching the policy report this morning after such hard work from the team. It has been a wonderful 9-month journey in collaboration with Novartis, with our external lead and our researchers on the ground, with our supportive partners on the ground and our stakeholders. The project here aims to understand the barriers to accessing early detection and optimal treatment for breast cancer, and also to identify policies for policy recommendations for a collaborative strategy to address these barriers in the next few years to come. Dr. Fatiha and also Kirjane will be presenting their work, but the structure of the project includes 3 different subsections. We started with a literature review of past work on breast cancer care here in Malaysia. We also had different focus group discussions with patients and also survivors from the Pink Unity Group, which is a cancer support group under the National Cancer Society of Malaysia. We also had a roundtable of discussion with the government agencies, the private sector, as well as the NGO stakeholders. So why is it so important for us to be looking into this theme now? This is indeed an important topic to revisit and re-examine. There are several reasons for this. Breast cancer remains the most common cancer, affecting 34 out of 100,000 women in Malaysia. Currently, breast cancer is the 2nd leading cause of cancer-related death in Malaysia, according to data available from the National Cancer Registry of up to 2018. Women who develop breast cancer have an 81% to 88% chance of 5-year survival, and this is for stage 2 and stage 1 respectively, if their cancer is diagnosed early, whereas these rates will be much lower for diagnosed cancer at stage 3 of about 60% and for stage 4 at about 23% of survival rate. However, when we look at the 5-year relative survival rates of breast cancer indicate in Malaysia that we do lag behind other developed countries and our other peers when it comes to breast cancer care. So in Japan, when we look at the international comparison of the 5-year relative survival period of diagnosis from year 2007 to 2018, we do see that Japan is leading, followed by US and also Australia. And we are not quite there just yet. Recent reports also demonstrated an increase in advanced stage diagnosis from 2011 to 2016. In other words, nearly half of the breast cancer cases were only diagnosed at a more later or advanced stages here in Malaysia. So advanced stage breast cancer due to late presentation brings about substantial medical and also non-medical costs to patients and also the families. Moreover, the research shows that breast cancer incurs significantly higher out-of-pocket payments as compared to other cancers such as colorectal, lung, and also prostate cancer. So on this note, the financial burden caused by cancer negatively impacts the patient's treatment choice and also adherence to treatment. And this will lead to the deterioration in the quality of life and also the psychological well-being of patients and the families affected. So this highlights the need to improve early stage screening and also detection, and to consider additional strategies to improve access to treatment for all stages of breast cancer. So given that delayed diagnosis and treatment have a significant effect on breast cancer survival rates, public health efforts may also need to consider various strategies to shorten the patient interval, diagnostic interval, and also in treatment interval in order to optimize clinical outcomes. So ladies and gentlemen, given these factors, I'm so happy that we're able to explore these issues in depth with the great help from different stakeholders, including our kind patient groups and policymakers and practitioners. It is from their invaluable input backed with data available could we have come up with a timely set of policy recommendations that would hopefully benefit the patients, practitioners, and families affected, as well as the policymakers moving forward. I thank you for your kind attention. Now, I would like to invite Yang Berusaha Encik Jega Deswaran, the Country Public Affairs Head of Novartis, to give his welcoming remarks.
Hormat Lukanisman Awang Sauni, Deputy Minister, Ministry of Health Malaysia, researchers and associates from Institute for Democracy and Economic Affairs, IDEAS, respected presenters, panelists, healthcare professionals, and honorable guests joining us today. A very good morning and welcome to the launch event of the report on breast cancer care in Malaysia, access to early detection, diagnosis, and optimal treatment. It gives me a great pleasure to share my welcome remarks on this momentous day in launching the report in collaboration with IDEAS, especially with the growing burden of cancer in Malaysia. Breast cancer remains the most common cancer among females, affecting 34 out of 100,000 women nationwide, and is still the second leading cause of cancer-related death in the country. As reflected in the National Strategic Plan for Cancer Control Program 2021-2025, the NSP-CCP public health efforts were put in place to improve early detection of breast cancer. Despite this, a significant proportion of advanced stage breast cancer remains a concern, with nearly 50% of the breast cancer cases diagnosed only at stage 3 and 4. This in turn leads to a poor survival rate relative to developed countries, further indicating a significant gap in breast cancer management. In order to downstage breast cancer at time of diagnosis by 25% by the year 2030, as aspired in the NSP-CCP, There needs to be a collaboration between the public and the private sector to reduce system inefficiencies, address resource constraint, improve data management, as well as to increase public literacy on breast cancer. Alongside ideas, the expertise and input were brought together through key stakeholders, service providers, patients, and survivors. Within this report, examining the barriers to assessing early detection, timely diagnosis, and optimal treatment. This brings me to the reason of our launch event here this morning, why this breast cancer care report and the recommendation can be a potential game changer within the breast cancer space, bringing value to the healthcare system, to the rakyat, for a healthy society and a better Malaysia. Fighting breast cancer takes everyone, and let's start closing the care gap today. Thank you very much. Enjoy the rest of the session and have a fruitful discussion.
Thank you, Jaga, for that kind message. I would like to invite YB Lukanisman Awangsauni, the Deputy Minister, Minister of Health, to deliver his keynote speech.
Dan salam Kerajaan Perpaduan Malaysia. The Honourable Dr. Juwita Muhammad, Director of Research Ideas Malaysia, Dr. Sauntari Somasundram, President of National Cancer Society of Malaysia, Dr. Zakiyah Muhammad Said, Public Health Specialist, Family Health Section, Family Health Development Division, Ministry of Health Malaysia, Dr. Azlina Firzah binti Abdul Aziz, Consultant Breast Surgeon, Pantai Hospital, Dr. Fatihah Hana Shahabaruddin, Department of Clinical Research and Pharmacy Practice, Universiti Malaya, Ms. Kirjen Ngu, Senior Research Executive Ideas Malaysia. Ladies and gentlemen, it gives me a great pleasure to welcome and to address all of you for the Ideas Breast Cancer Care Report launch, event organized virtually today. I would like to thank the Institute for Democracy and Economic Affairs Ideas representative and the team for collaborating and jointly organizing the Breast Cancer Care Report launch event. Breast Cancer Care in Malaysia, access to early detection, diagnosis and optimal treatment. Cancer is a leading cause of death worldwide, accounting for nearly 10 million deaths in 2020, with breast cancer being the most commonly diagnosed cancer type in terms of new cases of cancer in 2020, affecting 2.26 million people worldwide. Breast cancer also has a significantly higher disease burden as compared to other type cancers, demonstrated by the higher lost disability adjusted life years of women to breast cancer globally as compared to other type of cancer. World Health Organization, Internationally Agency for Research on Cancer, WHO, IARC, reports increasing breast cancer trends worldwide. As a middle-income country, the growing burden of breast cancer globally is very much reality for Malaysia. Sadly, compared many high-income countries where 9 in 10 women survive the disease, according to Malaysian study on cancer survival in 2018. Only 7 out of 10 breast cancer patients survive at least 5 years. In Malaysia, 1 in about 20 Malaysian women will develop breast cancer in her lifetime, with 8,480 new cases reported annually and 20 new cases each day, in line with Sustainable Development Goal 3, to reduce by 1/3 premature mortality for non-communicable disease through prevention and treatment by 2030. Public health efforts have been focused on improving the early detection of breast cancer, as reflected in the National Cancer Control Plan 2021 to 2025. Despite this late-stage presentation and relatively poor survival rates of breast cancer remain significant public health issues. Every year, the themes identified by WHO are always very timely and have a great significance to member states in all the regions of the world. While we'll join the rest of the world to observe the World Health Day today, I am happy to be part of this celebration. I shall spend the next few minutes highlighting a few salient points in relation to the theme for this year. Breast cancer policy in Malaysia. The National Strategic Plan for Cancer Control Program, NSP-CPP, 5M to downstage breast cancer at the time of diagnosis by 25% by the year 2030. The main strategy adopted to achieve this goal is through breast cancer screening. According to the World Health Organization, between 30 and 50% of cancer can currently be prevented by avoiding risk factors and implementing existing evidence-based prevention strategies. The cancer burden can also be reduced through early detection cancer and appropriate treatment and care of patients who develop cancer. The Malaysian government provides subsidized mammogram through the MOWFC and state government's program. Aside from screening program, this NSP CPP also highlighted the government plan to address the shortage of the breast surgeons, oncologists, breast radiologists and pathologists, as well as the need to develop additional expertise such as clinical genetics, genetic counselors, breast cancer nurses and mammographers. Furthermore, emphasis also have been given to improvement of infrastructure and equipment, the reinforcement and effective referral pathway, as well as the improvement of breast health awareness and literacy among healthcare providers and women. The Patient Navigation Program (PNP) was implemented in 2019 to strengthen the healthcare delivery support system, promoting timely diagnosis and treatment by eliminating barriers of care. Peka B40. Peka B40 is a government initiative via the Ministry of Health which aims to sustain the healthcare needs of low-income group by focusing on non-communicable disease NCDs. Peka B40 was initiated to avoid people from bearing the high cost for medical expenses later when they are diagnosed with serious disease. The Malaysian government has also carried out its Peka B40 scheme to raise interest for health screening. Furthermore, it has created awareness of performing breast self-examination (BSE) among Malaysian women and encouraged Malaysian women to come forward for clinical breast examination through social media platforms such as Facebook, Twitter and Instagram, while promoting the implementation of Breast Cancer Awareness Month on October. Through Peka B40, beneficiaries receive financial support such as subsidized health screening, complementing cancer treatment incentive (CCTI) or transport incentive. Thank you once again to IDEAS and to the organizing team for the work done for organizing of Breast Cancer Care Report Launch event. I do believe that with the line-up of experts from this forum from different backgrounds with commonality, their passion for breast cancer expertise, it will surely give rise to a lively discussion. May you all have a productive, fruitful discussion at the event.
Thank you so much, sir, for your kind message and also encouragement. Let us now move on to the presentation of the policy report. I am so happy to be inviting Dr. Fatiha as well as Kir Jain, who are the writers and researchers of this report. Dr. Fatiha, the floor is yours.
Thank you very much, Dr. Juwita, and thank you very much to all the attendees for being with us today at the launch of our report. So today I'll be presenting our report on breast cancer care in Malaysia, access to early detection, diagnosis, and optimal treatment. Myself and Kir Jain have been working alongside the team for the last half year on this report, and we hope that this can highlight some of the aspects that we may want to look into deeper as a society. So let's get yes. So today, an overview of what we will be presenting is we'll be talking about the current situation regarding breast cancer in Malaysia, based on the literature review as well as the available data from various sources in Malaysia, especially data from the Ministry of Health. Then we will be expanding upon access to early detection and access to diagnosis, which Kirjane will be presenting regarding what has been identified as certain barriers to access to early detection and diagnosis. And I will be following up with a presentation on the access to optimal treatment, particularly on the various types of treatment that are available for breast cancer care in Malaysia. Financial barriers is something that actually encompasses all of these intervals, the early detection aspect, the diagnosis aspect, and the optimal treatment aspect. So we will be also talking about that before we present our key recommendations that have emerged from the work we have done. So I'll be passing the floor to Kirjane to present the next sections on the access to early detection and access to diagnosis. The floor is yours, Kirjane.
Thank you so much, Dr. Fatiha. Salam sejahtera, everyone. Thank you for being here with us this morning. So please allow me to go through some of the background information just to set some context. And a lot of the things that we will be talking about are also issues that have been highlighted by our speakers in their opening remarks as well as the keynote speech. Now, just to again set the context that breast cancer is the most common cancer among women in Malaysia, affecting 34 out of 100,000 women nationwide. Now, breast cancer is the most prevalent cancer in the world, and it's very much also the reality for Malaysia. And given that the burden of mortality for breast cancer really varies based on the country's economic status, whereby lower and middle income countries have lower incidence ratios as compared to more developed countries. As a middle income country like Malaysia, the growing burden of breast cancer is very much a problem. In Malaysia, as mentioned, it is the most common cancer among women at the moment. Now, as mentioned in our opening remarks as well, public health efforts currently really focuses towards early detection through opportunistic mammogram screening, as well as clinical breast examinations, or what we call CBE. And these screening programs are usually carried out through government clinics, hospitals, as well as Clinic Nur Sejahtera. And these are all reflected in the National Strategic Plan for Cancer Control Program, or the NSP-CCP. Now, despite all these efforts, as you can see on my slide here, we have an international comparison of 5-year relative survival, and this is between the period of diagnosis between 2007 and 2011, and followed up to 2016. Now, if you can see on this graph, Malaysia really lags behind a lot of the other developed nations in terms of survival outcomes of breast cancer. So usually for developed nations, they range around between 80% to 90%. Whereas Malaysia hovers around 66.8%. Now, do take note that this data is a little bit outdated, but it is the latest, most available data that we have access to. So this gives us a gauge of what the situation is like. Now, despite, so on top of having relatively poor survival rates in Malaysia, we also face a huge problem of late-stage presentation for breast cancer. And this has been an issue for many years. And we all know that according to various studies and evidence that the stage of diagnosis is the most prominent prognostic factor for survival. So women who were diagnosed with advanced breast cancer have a significantly lower 5-year relative rate of survival. And if you can see on this graph here, it's stage 4. For women who were diagnosed in stage 4, they have a relative survival rate of 17.3. And then it goes up a little bit with an earlier stage. In stage 3, it will be 55.6, as compared to the earlier stages of stage 2 and stage 1 that hovers around 70 to 75%. So as you can see, the survival rates really goes down by quite a lot as you get late stage diagnosis. Despite this, nearly half of the breast cancer cases in Malaysia, and that's to be accurate, 48%, recorded by the National Cancer Registry, were diagnosed in advanced stages, and advanced stages would mean stage 3 and stage 4. Now, as mentioned, the relatively poor survival rates of breast cancer in Malaysia and the issue of late stage presentation really suggest that there have been significant gaps in our breast cancer management in Malaysia. Now, please allow me to also spend some time to explain the framework that we have chose to adopt in our study. Now, this is the breast cancer timeliness framework that we have adapted from Muja and colleague. So it was estimated that 88% of excess deaths due to breast cancer in Malaysia were avoidable, and with 57% attributable to late stage presentation and 43% due to lack of access to optimal treatment. Delay in breast cancer diagnosis and treatment are very much associated with larger tumors, lower cure rates, and poorer prognosis and lower survival rates. So it's really important that we really evaluate breast cancer care in Malaysia with regards to its timeliness across the patient pathway, all the way from early detection to treatment. Now, the time intervals serve not only as an indicator of the accessibility of healthcare, but also it helps us to identify the inequalities of care in patient management. Now, according to this timeliness framework, it's broken down into 3 different intervals of care. So firstly, we have the presentation interval, and then the diagnostic interval and treatment interval. Now, the presentation interval spans from the time from the initial presentation at the primary care facility based on the onset of clinical symptoms or asymptomatic screening to detect any breast abnormalities that warrants further evaluation. Whereas the diagnostic interval spans the period when the identified breast abnormality undergoes what we call a triple test based on clinical evaluation, imaging, and tissue sampling to arrive at a definitive diagnosis for breast cancer. Now, lastly, the treatment interval spans the time from diagnosis resolution to initial treatment. And as Dr. Fatiha has mentioned, treatment comes in many different phases, which Dr. Fatiha would expound on a little bit more later on. Now, let me focus on the access to early detection, which is the presentation interval first. So as you can see, I've circled the presentation interval here. Now, the presentation interval really is the time where people actually present themselves to any screening facilities just to get screened, whether or not they have the symptoms, right? So there is a wide spectrum of patients' health-seeking behaviors reflected in presentation interval, ranging from presenting themselves to clinical care through breast cancer screening to presentation from self-detected symptoms of breast cancer. So in order for us to effectively promote the early detection, we have to target both ends of the spectrums just to remove all these barriers to early detection. Now, Malaysia's approach, as mentioned, really focuses on opportunistic screening through clinical breast examination and mammography screening in public as well as private healthcare facilities. Now, since 2010, since 2014, the National Population and Family Development Board started providing subsidized mammography screenings or CBE through Nur Sejahtera clinics, as well as 15 family mobile centers to improve accessibility of screening, especially in the rural areas. On top of that, screening is also widely available in any government hospitals and clinics as well. Now, let me just quickly move forward. So since the implementation of screening programs nationwide, breast cancer screening uptake has noticeably increased from 2016 to 2014, if you can see my graph on the left. And as you can see, while clinical breast examination uptake has increased by a lot, the uptake for mammogram screening especially is still very low as compared to CBEs. And this has many factors, which I will expound on a little bit more later. But more importantly, I would like to also pay attention to the graph on the right that despite us having increased uptake in screening programs, we don't really see a downstaging of breast cancer nationwide. And this is quite alarming, and it poses the questions as to perhaps our screening efforts have not really translated to improve early detection. Now, if you look at the graph on the right, our advanced, still a very significant proportion of our breast cancer cases are diagnosed in advanced stages, stage 3 and stage 4. It hasn't changed much over the years, and it's still kind of hovering about nearly half of the cases. So that is something that we need to take note of. So we also know that mammography has been established as the primary and standard imaging screening modality for breast cancer detection. So given that mammogram uptake is still significantly lower than CBE, we really need to look into how do we boost uptake of mammograms, and maybe look into the specific barriers that hinders people from accessing mammograms specifically. Now, let me also go through this graph that we have here. So what we can see from this graph is that there is very wide range of mammogram uptake depending on the geographical location in Malaysia. So if you can especially pay attention to Terengganu and Kelantan, these two states have the lowest mammogram uptake as compared to all the other states in Malaysia. And this is alarming because it kind of raises questions as to perhaps there are specific geographical barriers that hinders individuals in these regions from accessing this very important mammogram screening. So it's been reported that women from rural areas, due to the lack of screening facilities and infrastructure and resources in these regions, women in these rural areas or men have to face higher travel burden to mammogram facilities as compared to in urban areas where screening facilities are a lot more accessible and available. So so on top of that, you have transportation costs as well as other aspects of out-of-pocket expenditure incurred due to these geographical barriers, which can, one, disincentivize individuals from presenting themselves for screening, and two, can also limit them from accessing these screening services even if they wanted to. Now, on top of these geographical barriers and issues with the lack of infrastructure and facilities, it was also reported that there are certain cases where individuals feel discomfort of seeking care or seeking screening services due to the presence of male doctors or male staff, especially doing their radiology appointments, mammogram screening appointments. So this is also another barrier that we do need to think about, to take into consideration cultural sensitivities or gender sensitivities when it comes to implementing screening programs. This probably also gives us an idea that we may have to look into prioritizing subspecialty training and upskilling for especially female nurses and radiographers. Now, moving forward, breast cancer screening efforts must really emphasize on routine or scheduled mammogram screening to achieve best clinical outcomes. So we know that evidence shows that regular routine mammogram utilization is most likely to yield early breast cancer detection. And as reflected in the previous data that I've presented earlier, the data mostly captured women who have ever done breast cancer screening in their lifetime. Now, ever done breast cancer screening in their lifetime is not so likely to translate into effective early detection, but what we need to strive for is to move beyond that and to focus on routine or scheduled mammogram screening. And this emphasis on routine and scheduled mammogram screening also needs to be reflected in the way we measure and monitor these screening programs that we are implementing. So current measures of screening uptake, as I mentioned, uses ever done as an indicator. So this does not really accurately capture the proportion of women who are adherent to evidence-based screening schedule that is recommended by the clinical practice guidelines, or what we call the CPG. Now, on top of issues, again, relating to lack of infrastructure, geographical barriers, as well as data monitoring, there are also individual factors that we need to consider. So these individual factors, for example, the public's health awareness and literacy actually affects or influences people's decision to present themselves to these screening services. So whether or not an individual is aware of their need to be screened, or whether he or she is aware of the urgency of breast cancer, that will ultimately influence their decision to go seek for mammogram screening as well as CBE. So across demographic and localities, poor breast health literacy is a significant barrier to screening and early detection. And this can be reflected in the lack of knowledge on breast cancer symptoms, or not recognizing the seriousness of breast cancer, or the lack of awareness of being at risk of breast cancer, or just simply not knowing or not having any information on where to go to seek for breast cancer screening services. So this really highlights the necessity of conducting a comprehensive, cohesive, as well as culturally sensitive breast cancer awareness campaigns and education programs, not just for women, but for men, for the general public. Now, let me also spend some time now focusing on access to diagnosis, the diagnostic interval. So screening does not end at early recognition of mammographic abnormalities, and prompt diagnostic follow-up is really crucial. So it doesn't matter that people get screened, but and if they don't end up presenting themselves to do a proper diagnostic test later on. So this interval is also very important for us to be looking at. Now, some of the factors that our study have highlighted in this diagnostic interval would be one, the disconnected referral processes from private and NGO facilities to public facilities. And I will expand a little bit more about that in my next slide. And secondly is generally the lack of awareness of non-lump symptoms and lump symptoms of breast cancer among not just the public, but also primary care healthcare workers. And this was reported in our study. It was also reported that symptoms without a breast lump were significantly associated with diagnostic delays. And there's also generally poor awareness, especially for non-lump symptoms among primary healthcare workers, leading to these patients not being urgently referred for further investigation. So that also again highlights the need for a comprehensive and continuous education for healthcare professionals, especially to look out for these kind of non-lump symptoms. So let me also talk about the disconnected referral processes in my next slide. Now, current legislation on patient referrals from private or NGO facilities to public healthcare facilities poses additional financial barriers. Now, we currently have this legislation, the Fees Medical Amendment Order 2017. This legislation states that it is mandatory for patients from private hospitals coming to public hospitals to be charged at the first-class rates. Now, this legislation assumes that patients who are referred from private hospitals are all patients that can afford healthcare, but that is not necessarily the case, as there are various reasons why patients would seek private healthcare first before opting for public healthcare. So one of the reasons could be, for example, if a patient would want to access screening, they would maybe prefer to go to NGO facilities or private healthcare facilities due to the long wait time in public facilities, or simply just the lack of screening services within the public sector across the nation, right? So there could be also geographical reasons to it. Now, this legislation, it was commonly reported that some patients who have detected breast abnormalities suspected to be breast cancer, while they did their screening in either private healthcare facilities or NGO facilities, when they wanted to do further diagnostic testing and preferred to do it in public healthcare facilities due to affordability reasons, they were simply turned away mainly because they had to be charged at the first-class rate. Or if they wanted to not be charged at this higher rate, patients are required to obtain referral letters from the government healthcare providers, either through Klinik Kesihatan or other means. But the point is, these additional layers really adds up to the referral processes and subsequently adding to the delays to diagnosis treatment. So what we see here is that this current legislation does not really take into account the patient's financial status. That's one. It it penalizes patients who were screened or diagnosed through efforts by NGOs or private health facilities. And it also exacerbates challenges of breast cancer NGOs in referring patients to clinical treatment later on. So this is something that we really need to look at. And we would also like to just present a quote that was taken from one of our roundtables, reported by one of our participants, talking about how NGOs are powerless when it comes to referrals. And perhaps we need to really start to think about how do we start to streamline these referral processes through perhaps public-private partnership, as well as other means. So I will pass the time now to Dr. Fatiha to continue on with the presentation.
Thank you, Kirjane, for that for starting the presentation and for allowing me to continue. I will be sharing my screen for the rest of the presentation. Okay. All right. I hope everything's clear on your end. So I'll be presenting what our report has found regarding access to optimal treatment. Now, the treatment interval comes after the presentation interval and the diagnosis interval. And there's actually multiple components to breast cancer treatment. So this is in essence a summary of the treatment. And, you know, a lot of patients actually go through this treatment and they can actually look back to it. So it's not actually sequential as how it's being presented here. So we have surgical treatment, radiotherapy treatment, chemotherapy treatment, hormone, endocrine treatment, targeted biological treatment, and finally palliative care as the key modalities for treatment for breast cancer. And it is important to look into the treatment interval as a comprehensive journey. For many patients, it is part of the continuum of care. Now, I'll be presenting barriers and gaps relating to each of these components of treatment in the coming slide. But what I want to actually emphasize here for this slide is looking at the treatment interval that we get from Dr. Mastura Muja's work and colleagues, is that while the treatment interval has an average of 21 days target, but what has happened in practice, if they have captured that it could range from 1 day to 7.2 months. So there is an urgency to actually address this, because delays in initiating treatment for breast cancer care can actually lead to disease progression. So gaps and barriers when it comes to the treatment interval, it actually varies with the treatment modalities. So the first one that I would like to discuss is the surgical treatment, which is the key treatment that is needed for many patients. Most breast cancer patients would benefit from surgical treatment, even patients with advanced cancer. But more importantly, for breast cancer patients who are in stage 1, 2, 3, and most of the time even stage 4, surgical treatment is necessary. However, there is limited availability of specialist surgeons within public oncology centers. And this will also link to radiotherapy treatment. Let me present that in the coming slides. So what we know regarding the barriers to breast cancer surgery in Malaysia is the key barrier is just seen in these numbers. So there at the moment, nationally, there's only 10 breast cancer and endocrine surgery subspecialty centers within Ministry of Health facilities. So 10 across the country is fewer than 1 per state. So what we see here is access may also depend on the locality, the geographic locality of the patients. And beyond the availability of these surgical subspecialty centers is that less than half, to be exact, only 22 out of 56 breast and endocrine specialist surgeons in Malaysia are registered to practice in the public setting. The rest of the registered breast and endocrine specialist surgeons are currently practicing in the private setting, which then also means that in this breast and endocrine surgery subspecialty centers, there are limited specialized manpower. Now, how has MOH actually dealt with this is commendable in that breast cancer patients in many MOH facilities are attended by general surgeons who are often trained because of the clinical need to perform mastectomy. However, to improve on that, I know that our YB Deputy Minister has addressed it, that this is a gap that has been acknowledged by the Ministry of Health, and efforts are being made to actually increase the number of the breast and endocrine surgical specialists who are practicing within the public centers. So how this relates to radiotherapy, I will actually present now, because it actually it ties together. So on one hand, what we often see now in clinical practice, and I think if we speak to people on the ground, is we hear mastectomy as the often is the most commonly received surgery for breast cancer patients. And this is actually partly due to the clinical need for radiotherapy if patients were to actually undergo breast conserving surgery. So this is why this slide is actually titled that optimal breast cancer surgery is limited by a lack of specialist surgeons and radiotherapy treatment. In the coming slides, I will actually present what are the available radiotherapy treatment in the public setting in Malaysia. But actually, I can tell you now that the number is actually fewer than the number of the surgical subspecialty centers. So what has happened here is, in order for patients to actually receive breast conserving surgery, to be eligible for that, many of them, a high proportion, would actually need subsequent radiotherapy treatment. So in order to receive breast conserving surgery, which is also known as a lumpectomy, patient will most likely be needed to undergo at least 4 weeks of radiotherapy. And then they would, if they are able to actually commit to that, then they would be eligible to benefit from breast conserving surgery. So in this case, the limited number of specialist surgeons and the limited number of radiotherapy treatment centers in the public setting actually renders lumpectomy, which is a breast conserving surgery, not accessible to many patients in Malaysia right now. So what has happened in practice is that's why it is more common to hear that patients are being offered mastectomies, which is the removal of the breast, surgical removal of the breast as breast cancer treatment. So on top of that, limitations, I guess, or restrictions and gaps within the healthcare system and the clinical need for the surgical specialists, there's also delays on the patient side in undergoing breast cancer surgery due to cultural misconceptions. So a local study has found that around 20% of breast cancer patients who have been confirmed with a diagnosis of breast cancer defaulted clinical treatment, with surgery being the most common treatment that was refused by patients. So it is important to keep in mind that anecdotally, because of how common mastectomies are being done for breast cancer patients nationally, most breast cancer patients by word of mouth would only know of mastectomy being the surgical treatment for breast cancer. And what has happened to this is, we will be honest, it's realistic that most women would be hesitant to actually go for the first line surgery, which requires the entire removal of their breast. And a lot more women perhaps are clinically eligible for lumpectomies or breast conserving surgery, but are unable to be offered breast conserving surgery because of lack of radiotherapy treatment that is needed to achieve the same clinical outcomes as a mastectomy. So with that being said, and knowing that that is the underlying background that could influence patients' decision to undergo surgery, what has happened is some patients refuse treatment and opt for alternative or traditional therapy. Of course, there are factors beyond this, but what we know for sure is at the moment, we have a need to actually enhance radiotherapy treatment so that the optimal surgery could be offered to patients in Malaysia, among other needs for the radiotherapy treatment, which I will expand on in the next slide. So commonly within clinical practice, patients may return back into clinical treatment, into the clinical service, into the health service with more advanced disease after having refused surgery when the cancer was first diagnosed. So issues regarding the surgical treatment, the limited availability on the optimal surgical treatment relates to the low number of the specialist surgeons as well as the limited availability of radiotherapy treatment. When it comes to radiotherapy treatment, it does link and have similarities in issues with the chemotherapy treatment in terms of the acute shortage nationally of oncology specialists and radiotherapy and chemotherapy facilities. So the two generally first steps for breast cancer patients when it comes to the treatment interval is the surgical treatment, which we know there's only 10 surgical centers for specialist surgeons in breast cancer surgery. And at the same time, there are only 9 centers nationally for radiotherapy and chemotherapy facilities. And there's also an acute shortage for oncology specialists. And this again becomes another key barrier in the treatment interval. So the limited availability of radiotherapy and chemotherapy is related because generally the public oncology centers nationwide, there are 9 public oncology centers nationwide, and these are the only ones that offer both systemic chemotherapy and radiotherapy treatment. And this acute shortage of oncology specialists has basically less than half of the estimated 150 oncologists in Malaysia practicing within the public system. So for both the breast and endocrine surgical specialists and the clinical oncologists that are in Malaysia, less than half of the registered specialists practice within the public system, and therefore more than half are practicing in private health facilities. So this limits the availability of radiotherapy and chemotherapy, which is commonly the next subsequent lines of treatment that is needed by many patients after surgery. There's also the link between the type of surgery that is available to patient with the need for radiotherapy afterwards. So these are the barriers that are being faced acutely in the treatment interval. So I would like to expand on how these two actually links up to each other, because the surgical treatment and the radiotherapy and chemotherapy treatment are considered the backbone of the treatment for breast cancer. And addressing this gap is something that we know that MOH has acknowledged. However, at the moment, this acute shortage is actually affecting many patients on the ground, and perhaps it is time, I'll address this in our key recommendations, perhaps it is time to think of more immediate strategies while we have the capacity building aspects that's going on in dealing with the treatment interval, issues within the treatment interval. Okay, beyond this, beyond the these 3 key treatment, which is surgical and radiotherapy and chemotherapy treatment, the subsequent treatment that relates and is needed is part of the multiple treatment modalities that is needed by breast cancer patients is the hormone treatment as well as targeted biological treatment. Now, hormone treatment is actually more widely available than surgical and radiotherapy and chemotherapy and even targeted biological treatment, partly because it is actually a tablet and it is more widely available because it can also have like surgical and other clinical specialties helping with the treatment in terms of monitoring and prescribing. The thing about hormone treatment, the long-term duration of endocrine therapy, long-term treatment is needed in order for patients to actually benefit from treatment. And by long-term, we're talking about 5 to 7 years. That's what current data indicate, that patients would benefit for being on treatment between 5 to 7 years. And this means that adherence to treatment is really important in order for patients to benefit. Targeted biological treatment is generally less available in the public setting, and partly because it's also being prescribed by the clinical oncologist. So it's facing the same barriers when it comes to targeted biological treatment. It has the same barriers as radiotherapy and chemotherapy treatment, in that less than half of the registered oncologists in Malaysia are practicing in public centers. And when it comes to that, that would also make sense that we hear a lot that targeted biological treatment are available or are more widely spoken about in the private setting, because the majority of our oncologists are working currently in the private setting. At the same time, targeted biological treatment has an additional barrier in that it actually has very high treatment costs, higher than radiotherapy and chemotherapy, and sometimes higher than radiotherapy and chemotherapy combined. And this makes it less available, limited availability within public healthcare facilities, because the high cost of targeted biological treatment becomes an additional barrier in the treatment interval. Now, knowing that nearly half of our breast cancer patients in Malaysia are diagnosed with advanced breast cancer, a huge proportion of patients would eventually need palliative care. And currently, palliative care services is still not widely available within the public setting. So palliative care specialists are limited in number, as it currently is, and also the limited provision of palliative care services also links up and relate to other diagnosis and other clinical conditions that require palliative services. So this is not specific to breast cancer. And similarly, when it comes to issues and regarding the barriers for radiotherapy and chemotherapy treatment, of course, it's not specific to breast cancer, but breast cancer is the most common cancer that we are facing in Malaysia, and therefore the impact on breast cancer patient is significant. So these 6 treatment modalities that we are presenting today actually have got their own barriers that need to be addressed, and there is a need to actually look into each component to make sure that we can actually enhance and optimize the continuum of care for breast cancer patients in Malaysia. So while the breast cancer patients are undergoing the presentation interval, which leads, which starts from the date of the first symptom discovery, when the patient first discovered the symptom, either through screening or even breast self-examination or clinical breast examination, and then undergoing the diagnosis interval, and then finally getting to the treatment interval. Throughout the entire journey, breast cancer patients of various income levels face a wide spectrum of financial barriers. And without a doubt, this journey is a long one. For many patients, because the good news is there are some enhancement of survival from all the clinical care that is available. But that also means that patients are going through this for a prolonged period of time. So when they're going through, especially treatment can take a long time, then the financial barriers and the financial issues that patients face is enhanced over time. So patients from low and middle income household, we know that data indicates that the financial barriers that they face could start from the very beginning, even at the presentation interval, because even presenting themselves for clinical care will require expenditure, sometimes even to get themselves to the healthcare facility, or even to take time off work or arrange childcare. And all of those can actually manifest as financial barriers, and it could present as early as in the presentation interval. The diagnosis interval also often requires, even if accessed in the public setting and there is no out-of-pocket payment needed to access healthcare, but there could be other direct non-medical costs that the patients are facing, such as transportation costs, childcare costs, and all the other issues that needs to be resolved. So we know that the current schemes, MySalam and Perker B40, is available for patients from the low and middle income households. However, quantitatively, it may not be enough for this long journey that breast cancer care usually requires. From the current evidence, from the current evidence and anecdotal discussion, it seems to indicate that patients from high-income households are more likely to face financial barriers and issue when it comes to the treatment interval, because by definition, and from what the data we know, high-income households are also more likely to have savings that can help them in the presentation interval and in the diagnosis interval. However, the high treatment costs, if accessed within the private setting, or even the long duration of treatment that requires a lot of incremental costs in terms of direct non-medical costs for the patients in order to access treatment and actually going to treatment. Chemotherapy is a long treatment. Hormone treatment is also another long treatment, and if patients are able to access targeted biological therapy, is also a long treatment. And of course, radiotherapy itself, while it tends to be every day for 4 weeks to 6 weeks, then it would also require daily attending outpatient radiotherapy treatment daily. So this would even affect high-income households. Patients from high-income households are also affected by the financial issues and barriers, which is commonly happening in the treatment interval. So knowing that the wide spectrum of financial barriers is happening to patients from all households, really all income households, what we are also acknowledging in the report is that there are funding constraints within the healthcare system, within the healthcare budget itself, that becomes a systemic barrier to breast cancer care, because this influences the availability and accessibility of treatment. As I have presented in previous slides, this affects the surgical treatment and radiotherapy treatment, and of course, chemotherapy treatment and all the downstream treatments as well. So the current increase nationally in non-communicable diseases need to correspond with increased healthcare funding at the national level in order to address these issues. So I would like to present now the key recommendations that has emerged in our report. So the first one is we see the need to facilitate a public and private partnership, a public-private partnership that could be seen as how we set up a National Breast Cancer Committee to foster collaborative effort between stakeholders. Because currently there are no National Breast Cancer Committee that would merge the private and the public healthcare providers. We also need to streamline referral process and formalize collaborative care between public and private health facilities, which would allow for a smooth referral process. Finally, we need to actually develop a collaborative database, because currently all of the resources and pathways to access breast health screening and clinical care is not known to others. So as in, like, people are only knowing it when they are informally talking to each other, and there is no one-stop resource center to refer to. We are also wanting to, the next recommendation is to increase financing of breast cancer care. And this would, of course, increasing resource and budgetary allocation within the public system, and to review and revise the legislation that currently mandates first-class rates for patients who are referred from the private health facilities, as was explained by Kirjin earlier. There is also perhaps a need to regulate cancer treatment charges in private health facilities, so that perhaps maybe the public patients could be sent for treatment to relieve burden within the public healthcare system and increase access to patients, which we know have been done for COVID patients, and therefore maybe a similar template could be used for breast cancer patients. Finally, there is, second last, thirdly, there is a need for a cohesive breast cancer awareness and literacy campaign, and that needs to be for both the public as well as the primary care healthcare workers and healthcare workers in general, to increase awareness of non-lung symptoms and risk factor, and to increase the number of culturally sensitive breast cancer awareness programs that are available nationally. Finally, there is a need to increase the quality of breast cancer data management by making perhaps current available data tends to be capturing, current available data, it does not actually require compulsory reporting of breast cancer cases. So there is a need to improve documentations on perhaps by getting compulsory reporting in public and private healthcare facilities, as well as capturing adherence to scheduled screening according to CPG recommendations. So these four key recommendations emerge from our report, and I would like to pass the floor back to Dr. Juwita to continue with the launching. Thank you. Here are our references.
Thank you so much, Dr. Fatiha and Kirjin, for that very extensive presentation. We have a lot of food for thought for our next section of the launch, which is the panel discussion. In this session, I will be the moderator, and I would like to introduce my co-moderator, Julia. She will be collecting all of your questions from the Q&A box. And I do see that Puan Zuraini Cekla has raised her virtual hand online, but Puan Zuraini, if you could also just put your questions in the Q&A box, that would be highly appreciated. So yes, let us now move on to our panelists. We have three panelists today to discuss the report, and also to get, we are here to also get their views on the challenges that they face on the ground in their different capacities. We have Dato Dr. Sauntari Soma Sundaram, the President of the National Cancer Society of Malaysia. We also have Dr. Zakia Muhammad Said, the Public Health Specialist at the Family Health Section of the Family Health Development Division at MOH. And we also have Dr. Azlina Firza Abdul Aziz, who is a consultant breast surgeon at Pantai Hospital. Welcome, everyone. So I think maybe we can start off on something that is like as an icebreaker, on how you see and you view the policy recommendations and also the findings from the report. Dr. Sauntari, could I get your views on that?
Thank you so much, Juita. It's wonderful to be here and to actually hear the whole report and the findings from the report. I think it's fabulous. I think in the sense that it's cohesive. It puts everything together into one report. Unfortunately, what I would say is that many of the facts that you have put there, many of the recommendations that you have put there are recommendations and facts that we have known for a few years. And now I think what we need is action. What we need is to move forward. Now we have it in a cohesive report, in one report, the different aspects from screening to diagnosis to treatment, but we need actionables from there.
Thank you, Dato. Dr. Zakia, may I also get your input on the findings as well as on the policy recommendations that were presented earlier?
So thank you, Dr. Juwita, for organizing this program and also initiative. So thank you again for inviting me to be paired with all the panelists from the different organization and also the different medical background. So in terms of the report, I'll say that I should echo with what Dr. Saundari has mentioned just now, because this report is actually a very, very good report, especially for me as a policymaker at the Kementerian's level. So most of the report's content is actually has been acknowledged by us, especially at the Kementerian's, okay, looking at the gaps and also the challenges and also the way forward. And I must say that towards to improve the gaps and also the way forward, we need actually to have a very good governance, public-private partnership, so that all the resources and also all the necessary actions can be made meaningful, especially to the rakyat, for the benefit to the rakyat themselves. So that is my general opinion. Thank you.
Thank you, Dr. Zakia. Dr. Azlina, you are one of the reviewers of this report. Thank you so much for your support and your contribution as well. What is your take on the overall findings as well as the policy recommendations?
Thank you, Juwita, for organizing this much needed forum that we initially met last year, right? And what has been concluded by the report by Dr. Fatiha and Kerjane and the team in Ideas is that there are many gaps that we need to look into. Overall, sometimes on paper, things look fine, but if any patient is actually put into the system, there will be discovery of certain things that should not happen, but happens. There are certain, there's some data that was presented that makes me and Dr. Soundry wonder actually which center claims that they can initiate the treatment within 21 to 24 days. We wonder whether it is a private hospital or is it a public center, because generally it is very difficult to initiate treatment that soon. You know, the problem is very systemic. It's right from poor awareness, poor access. In between, you do have gaps where the patients actually, because of poor access, they go to NGOs or private hospitals, but they're not actually financially well off. And then we have that gap where everybody who comes from NGOs or private centers need to be charged first-class fees. So that one is something that I knew if a patient is referred from a private hospital, but I only discovered it last year that even referral letters from NGOs, and a lot of NGOs actually do a lot of screening for breast. And this, I feel, can be corrected because every public hospital has a Jabatan Kebajikan, and patients can actually be screened by whatever means that are already there. Because I do remember from my public hospital days that if some patients are financially short, we refer them to Jabatan Kebajikan, they are assessed and they are given some sort of stipend or help. So these are the things that we need to really find out. Why is there such a thing as labeling everybody who goes from private to public having a lot of money? I mean, based on what? You know, there must be some ways to screen them properly. And at the end of the day, we do want better collaboration between the public hospitals, the university hospitals, and the private centers, because the facilities are there, and of course, it needs a lot of money to duplicate a lot of these centers, setting up, for example, centers that provide radiotherapy services is not cheap. And we know that certain states do not have radiotherapy services, therefore they don't have regular or resident oncologists, because you see, if you don't have the facility, why should the person work there? So it's a chicken and egg, you know, or we don't have oncologists. Oh, but why should you have a resident oncologist when you can only have a little, a percentage of the armamentarium, your facilities, the infrastructure to treat the patients that you really want to treat? So I think this is, as Dr. Soundry said, your conclusions and recommendations are very good. We need to act now. We could have, we needed to act yesterday or 10 years ago. No. And we still know that breast cancer is the highest cancer in Malaysia. Why? We need to move on. We need to improve. It frustrates many people and patients, and it is sad.
Thank you, Dr. Azlina, and improve we shall. Going back to Dr. Santari, what is the main approach and focus for the National Cancer Society of Malaysia in improving breast cancer care in Malaysia? If you can share with the audience.
Okay, the National Cancer Society has been around since the 1960s, and we started focusing on breast cancer from the 1970s. So historically and now, the focus is really the creation of a breast cancer literate society through the awareness and education of being breast aware, screening and early detection of cancer. So that's our core, really. Having said that, I would say that this encompasses both genders, female and male, because I think, if we just focus on the female, we're not getting anywhere. We need to make it more inclusive. Because breast, as Dr. Haslina said, breast cancer is the largest cohort of cancers in the country and globally, and it's not a health issue. It's a societal, a community responsibility, and it shouldn't be hidden in the recesses of the health segment or the women's segment of our lives, but should be front stage and free from stigma and prejudices. How the National Cancer Society does all this is, we have the largest breast cancer screening network in Malaysia. So we utilize our own center, and we also utilize private facilities to provide free and subsidized mammograms. So free mammograms to the B40s and subsidized mammograms to the rest of the population. We provide around 12,000 free mammograms annually. And this is a partnership. It's just not us, doing it. It's a partnership between nonprofits, ourselves, other nonprofit organizations, government, corporate and private healthcare facilities. And because we have this partnership and this collaboration, we're able to do the numbers. We also do breast screening for those who are high risk and below 40s. We do community health education and, empowering cancer survivors to be advocates and developing young and community cancer advocates. And I think that's important. We're not going to change behavior if we don't change mindsets. So that is really in terms of the early screening aspects or the early prevention aspects of breast cancer. But a lot of the work nowadays that we do is to focus on support of individuals with breast cancer. Juwita, you mentioned Pink Unity before. That's a peer group support, women's peer group under the National Cancer Society. But what we do is also to try to decrease that diagnostic interval that you were talking about earlier. And so we provide diagnostic facilities to enable faster processing through the diagnostic intervals by subsidized imaging on CT scans, PET scans, and biopsies, and of course the referrals. And you've mentioned this whole disconnect between referrals from NGOs to the public healthcare sector. I mean, that is a low-hanging fruit, and I think that is something which can change quite rapidly. We do patient navigation support systems and patient access programs for medication. So what we do here is that we provide or we enable patients to access medications through us at a lower rate, which they can utilize within the public healthcare service in terms of medications which are not provided or not accessible in the public healthcare service. And of course, psychological support, etc. So basically, we try to do the whole continuum, except for palliative care, which they are better experts than ourselves.
Thank you, Dato. Dr. Zakia, I was just going to ask you, in terms of making improvements, what is MOH strategic focus now on improving breast cancer care in Malaysia, and what are some of the examples of programs that MOH has implemented under the 2021-2025 National Cancer Control Plan?
Thank you again, Juwita. So as you know that basically the main role of Ministry of Health is actually to prevent and control the disease. Once get the disease, we treat and also manage them properly. And we do kinds of rehabilitation, palliative care, and so on and so forth. So that is actually the general role and the general role of Ministry of Health. Okay. So these are all the strategies, especially for the cancer, has been actually entailed and also explained very well and very comprehensively in our NSPCPP 2021 to 2025. And I must say that, because I'm in charge for both the women's health cancer, so for my cervical and so for my breast cancer, I must say that I'm quite doing for me, I'm quite doing a very, in terms of the so-called advanced job for cervical cancer, because we have nowadays the latest screening tool. So we are now trying to pushing the policy towards HPV testing. So that is actually the latest development of the program for cervical cancer. For the breast cancer, I foresee that I'm going to mimic the same thing that I have done for my cervical cancer. For the first one, our main focus is actually, we need actually definitely improve the awareness, because the study has shown that everything that are related with increased morbidity and also mortality in the country, some way or somehow is actually related with the health literacy of that kinds of the populations. So that is actually our main focus, to improve and create awareness. So continuous awareness to the rakyat. Okay, but now we are trying to deviate the breast and cervical cancer. We are not going to say that all women need to know that, but we have to say that we try to move from the word of women. Now we have to say that all masyarakat and all the community in Malaysia have to know about the cervical and also the breast cancer, because we have our mothers, our sisters, and also our wife, and also our children. So basically, awareness of this, the sign and symptom, especially for breast cancer, is actually a must for all types of the community in Malaysia. So number one, to improve the awareness. So number two is actually our main focus is we'll try to improve the services, because for me, like, I'm more focused on the prevention and control program. So we do more on like early detection and early diagnosis program through our screening program. So that is the thing that we are going to do, and our main focus, to improve the screening, to improve the coverage of the screening, and also to do the necessary intervention. Because when we are talking about the screen, there's no point screening and then you stop. Okay, you screen, you detect, and your responsibility of doing the intervention, like follow up, refer them to the centers that are responsible to do the secondary or tertiary care. So we are going to strengthen on that. Rather than screening, mass screening, we need actually to create a very quality types of screening and intervention. So that is actually our pipeline, our main focus. And number three is actually, once we have our screening, our early diagnosis program, we need actually to see the data. We need actually to monitor, and also we need actually to evaluate through our analysis and so on and so forth. So this is actually the way that we can know which or what gap that we need actually to tackle. And besides that, maybe the data alone is not enough. We need to collaborate in terms of giving a high impact research. So this is very, very important, especially for the recommendation on the policy direction, because we know that sometimes, okay, the WHO or the worldwide have actually announced a few strategies, advanced strategies towards prevention and control. We need actually to align with that strategy as well. And number four, our main focus is actually, we need actually to increase and we need to improve the collaboration. Okay, we need to intensify the collaboration efforts between the key stakeholders, not only public, private, but also all the NGOs. Okay, the key party, even the what we call the PBTs, okay, the state development, because sometimes some of the services also run by the state authority. So we need actually to engage with all the main key stakeholders to maximize the services and also to maximize the resources that we have. Because I believe that resources is not only through KKM. The resources is also was there in Kementerian Wanita. The resources was there in some of the NGOs. So we need actually to collect all the resources and put them and try to provide the services as the best as we can. So that is actually my comment. Thank you.
Thank you, Dr. Zakia. Dr. Azlina, you are a breast surgeon and have been in both, contributing in both the public and also the private sectors. Can you expand on your experience a bit, looking at the ground, treating the patients? What is your take on the biggest challenges there on the ground?
Thank you, Juwita. Let me just start from the very beginning. Patients that are usually more aware about their breast health and are also have knowledge from, say, their close relatives who have had breast problems before, they usually can gain access quite easily. See, in Malaysia, we don't have the family GP concept like in most developed countries, where you have to make an appointment to go to your family GP, and then you may or may not get referred to a specialist center. But in some countries, the family GP organizes mammograms and ultrasounds and biopsies before they refer them to tertiary centers. But here in Malaysia, the good thing is any patient can walk into any GP clinic or any tertiary center, even without a referral letter. So there are those who are already in the know of, they know what to do. And usually once they get into, I will speak first on the private center. Once they walk in and they are investigated, they get an immediate imaging. Either they need an ultrasound or mammogram plus ultrasound. Biopsies can be organized, and within 3 days you get a biopsy result, and then we can organize whatever treatment is needed. Well, I spent a total of almost 18 years in Kementerian as a government doctor, junior doctor until specialist level, and about 5 to 6 years as a specialist there. So definitely the patients that I saw in public hospitals came much later. And of course, the data shows that about half come in stage 3 and 4. But within each unit or department where any general surgeon or breast surgeon sees the patients, there are ways to organize expedient management and treatment. In breast cancer, as in many other cancers, it is best that you have multidisciplinary teams where you speak the same language with the radiologists, the pathologists, and you organize how to get results faster. Patients who come in later stages are then organized to have maybe a chemotherapy or targeted therapy or combination of both prior to surgery. For those who need surgery in private, of course, you can book them within the week when you get your biopsy results. Yes, I do understand. I worked in government hospitals before. There are wait lists, but there are always opportunities to allow the patients who are confirmed cancers to have their treatments faster compared to the benign cases. In terms of collaboration in the last 3 years, only towards the end of our pandemic, there was some collaboration between the public hospitals and private hospitals, where the patients who were sent from centers that were designated as fully COVID centers and their operating theaters were reduced or closed. there were some patients that were sent to us. However, all these processes actually, because it depends on when they come, and we know the survival of breast cancer, the good results will come only if they come in the early stages. And I agree with screening, something that Dr. Santri said about not just labeling as breast cancer as a woman's problem, because when I give talks to the public, when we get invitations from officers or institutions, they always tended to allocate Friday lunchtime as the talks for breast cancer awareness. And I used to tell these organizers, listen, this is not just a woman's problem. And usually I will only get the technician for the projector as the only male person there. There are many, many instances over the years where the male partner is the one who actually discovered the breast problems. So we need to rope in the male genders to say that this is not just purely a woman's problem, because if the woman is the mother and wife, if something happens to the mother, the whole family collapses. This we know happens. So we need to make it a community problem or a national problem. The numbers are, well, we don't have the latest numbers yet. I'm pretty sure it hasn't gone down. And because of the pandemic, we have seen a lot of delay, not only in the public hospitals, but also in private, because people were too scared to come out, although the private hospitals stayed open. But most people did not access because they were living in fear. So in the last more than 6 months or so, we are seeing patients who have come in stage 4 fungating breast cancers. It is a problem in public hospitals as well, not only in public, both places. So the teams that was mentioned in the recommendation, getting a national type of collaborative work done, it is probably looking at something like a multidisciplinary team, because we need to not only involve the surgeon, we need the pathologist and the radiologist to understand that once the patient can get into the system, we need to move faster, because delays put them in a worse state. Basically, the difference between in public setting and private setting is that the speed of things. And even in private hospitals, if your imaging department does not have any radiologist who is interested in breast, sometimes there can be some delay, even the reports. So I feel the multidisciplinary collaboration in the among the key people, the surgeon, the radiologist, and the pathologist is really key to getting faster results, better results for the sake of the patients. So it is a good idea, but let's see how we can get it going. Thank you.
Thank you, Dr. Azlina. Dr. Santori, I was just wondering, as an NGO practitioner for more than a decade, what are some of the developments in breast cancer care over the past few years, and what do you see as the persisting gaps on the ground?
I think the first thing is that the noise around breast cancer. I think it's wonderful that there's so many more players in the field when it comes to breast cancer. And when we talk about players in the field, we're not just talking about Ministry of Health and NGOs and private hospitals, etc., but general public, general corporations, and everyone actually knows about breast cancer now. The issue about that, though, the general noise, is that there's a lot of noise and too much noise and disparate noise. There's a lot to get through in terms of the noise, and the key messaging, I think, gets a little bit dampened, or it gets lost in everything. But what it has done is that it has lessened the stigma and the shyness about talking about breast cancer, or about breast health itself. But talking is one thing. What we haven't got is behavior change. And that's what we need to initiate. We need to initiate that behavior change. How do we do that? One, Dr. Zakia, it's wonderful to see what Ministry of Health is doing. I think in the last, it's been more than a decade that I've been in this. Azlina and I have been there for many decades. But what the change we've seen is that there's always been a focus in terms of treatment, but there's a lot more focus now in terms of prevention and early detection. And that is one of the key changes. And that is the change that needs to happen. That's where the urgency needs to be. That's where the momentum needs to be. Because, as Lena said, and as I think earlier Dr. Fatiha said, treatment is there. We have treatment options, but to get them to that point in a timely manner where your breast cancer is not in stage 4 or in stage 3, but get them in a timely manner where the treatment can be effective is key to everything we do. So, this upstream that we need to get down pat and get organized, I think is where the urgency is. In the report, it was mentioned that, yes, mammography has increased to 24%, but we're not seeing downstaging. You can't expect to see downstaging at mammography at 24%, full stop. We need mammography nearly up to 70% to see a downstaging and to see, mortality reduction of about 40%. And that's what you see in other countries. That's why other countries have got such good results. It's because we have mammography up at such a high level. So we need to do more to increase that. And yes, government in terms of, or Ministry of Health in terms of mammography is mostly diagnostic. It's not screening. So there needs to be more collaboration between NGOs, private institutions, to get that uptake in mammography. And I agree, in certain pockets within the country, there aren't facilities. But now with mobile units, with the private centers having more mammography screening, it can be done. It just needs to take that concerted collaborative effort for it to be done. And we've shown at the National Cancer Society with the program that we do with Etika, which is a private organization with a corporate who's funding it, that it can be done. You can get free mammograms out there. You can get access to mammograms out there. So, so the capacity is there. We need more partnerships in that. Having said that, we also need to stop putting up barriers. And I think we're very good at putting up barriers and telling ourselves, oh, it can't be done. We need, as Dr. Zakia said, we need to deep dive into the data, identify pockets of the low-hanging fruit which is there. Not all Malaysians are equal, not all of Malaysia is equal in services or attitudes. Therefore, there's no cookie cutter, there's no one fits all. So mammography might not fit everyone. We need to localize what we have out there. For example, we talk a little bit about, culturally sensitive or appropriate services. And I rail about that a little bit. I get a little bit angry about that sometimes because I think it's a barrier that we put up ourselves. Yes, I agree. We should reach out to communities in the way that they feel more comfortable and able to absorb the information and accept the information. However, you know, if a woman was in a car accident and at death's door from her injuries, nobody is going to stand there and say, oh no, we can't give treatment because it's not culturally appropriate. Breast cancer kills. It's not an instantaneous death, but it is a messy death. It can be a slow, potentially painful, heart-wrenching demise. And we have to put that urgency into it. You know, we cannot allow it to happen because we sit there and say that, well, maybe it's not culturally appropriate to do it this way. Fine, you know, if that is not acceptable, we have to work around it, you know, how do we make a difference? And I think here education can make that difference. And I'm not talking about just education through a health directive or a health direction. We need to be inclusive, as I mentioned before, and Dr. Zakia also mentioned, and Dr. Azlina, that, you know, we can't just focus it on women. We have to talk to community leaders, religious leaders, husbands, fathers, etc. You know, make them part of the solution and not the barrier to breast screening and early detection. Teaching about breast health as part of our school education, encouraging dialogue as part of the change, you know, and getting local champions. If we can't do mammograms because of these issues, you know, we need to adapt. We talked a little bit about CBE, and yes, CBE has increased to 68%, but at the same time for CBE, you need specialization, you need experts to do the CBE. IARC, the International Agency for Research on Cancer, in November 2022 had a multi-pronged study, which they did, stated that improving awareness on breast cancer early signs and the importance of early detection, coupled, of course, yes, with access to timely treatment, is an equal pathway to doing CBE. So if we can't do, you know, give services because of it being, we don't have the specialty or we don't have the resources to give culturally appropriate services, you know, we need to push that whole idea of early detection and education, and women and community taking health into their hands as well. It can't be pushed back continuously to the, it can't be pushed back continuously to, or, you know, the government doesn't give us enough, or, you know, we don't have enough resources, etc. We need to change attitudes in people to realize that health is within their own hands as well. It is not someone else's responsibility, it's our individual responsibility. So it's not just services that, you know, the report focused a lot about the services which are out there. But I think what we also need to overcome are the barriers that we put to people taking responsibility for their own health, their own personal responsibility and community responsibility.
Thank you, Dato, for that. Yeah, for highlighting that. That is a very important point, indeed. Would you like to add something more?
No. I just wanted to say also, you know, that's key. I think, you know, that's one of the key issues. But I think the secondary issue is what we mentioned as well, is the navigation aspect of it. Is how do we get it in terms of a timely diagnosis? How do we navigate between primary and secondary healthcare and make it easier for patients to move between the two sectors, be it in terms of referrals or be it in terms of utilizing the age of digital technology. At the moment, patients still get a written referral letter, you know, from a general practitioner, which they have to take to a hospital, and then the hospital then has to go and, you know, get an appointment. So there are many steps. We need to be able to pick up the phone or use the computer or do something to be able to get these referral pathways done pat without the patient having to run from one institution to another institution. Yep. So yeah. those were the two areas that I think I'd like to highlight.
Thank you, Dato. Dr. Zakia, what is your take on the main challenges faced by MOH in providing timely and optimal diagnosis and treatment for breast cancer? You mentioned awareness just now, but what are the other challenges that you see?
Yeah, I think that the awareness is of course the number one, and then the number two is actually inequalities of getting the services, especially when we are talking about the specialized services, especially for cancer, the radiology, the radiotherapy, the chemotherapy, and also the surgery itself. So we know that basically all kinds of these services are very concentrated at the city level. So this is actually one of the access issues, especially to those at the kampung area, at the rural area, the lower income group of people to come and access. So accessibility in terms of the inequality is actually one of the main challenges facing by our countries. Okay. And number three is actually, of course, when we are talking about the challenges, it's always tied up with dollar and cents. So it can be actually reflected in our usual yearly gross GDP. So we know that from the reports and also from the news, okay, so our health in Malaysia is actually getting very low in terms of the expenses. So the resources we can tie up the resources in terms of the service delivery, the operational money, the resources in terms of getting replacing the new equipments, because we know that some of the facilities have the old equipment like the mammogram machines, which can be, I think, 5 to 10 years is quite common, okay, because we don't have actually enough budget to replace that with a new. And then resources in terms of the manpower, as has been mentioned in the study, because we are very lack in terms of the specialized manpower. So that is actually a few things, the resources constraint. And I think number three is most important thing that we need to accept that we have a very, fragmented healthcare system. So as usual, our healthcare system is actually the dichotomous healthcare system. We have a public, private. So this is actually something that very difficult, because we know that some very common reasons are all the policies that have been directed from the Ministry of Health is not actually keep known to the private or NGOs. That is actually common and it's true. So I think that's a good suggestion that we need to have a one body like MOH, because in terms of the government itself, besides MOH, Kementerian Wanita is also doing the same thing with us. But we are actually looking at the different aspect, and Kementerian Wanita will be looking at the different aspect. So this is actually when we are talking about the government itself. So we are not talking yet about the private. So I think the first thing we need actually to look and to coordinate that them properly. And because by having these kinds of issues that we can address and accepted by the top management is a potential, and this will lead us to the potential way to solve it further. So I think basically that are the most common challenges that are facing by us at the ministry level.
Thank you, Dr. Zakia. Dr. Azla, you also mentioned about awareness just now, and from my conversation with you in the past, it's not just awareness, because some patients are aware of the issue, but then it's because of cultural roles as a mother, as the responsibilities in the family that actually hinders them from getting timely treatment. And I was just going to ask you to comment on this as well, that it's kind of a multifaceted issue that we have here.
Yes, thank you, Juwita. I think when we sit and listen to what problems that the patients tell us, yes, definitely is not exactly excess. There are also not exactly financial issues there, because we live in Asia, and sometimes there are still pockets of the population where the women are still being treated as second-class citizens, or when they feel that they need to visit the doctor, something else always crops up, and they tend to delay getting access to a proper consultation. The understanding about breast issues, I think it is generally improving from the past, say about 20 years ago, where there would be very, very sad cases where the women would be left to fend for her own or divorced if she agreed to sign on the consent form to have a mastectomy. It had happened to one of my patients where the husband threatened to divorce her. And later we found out that it was because some of his male friends made jokes saying that he's now married to half a woman. See, statements like this don't help. And there will still be pockets of population. And I do understand from my gynae colleagues as well, the problems also arise when the women have to have hysterectomies due to cancer. They will make jokes that, again, the women are left to be half women and not a full-grown woman because they have parts taken away. So there is still, we need to understand. We may not agree, we can beg to differ, but we must know where these ideas come from. It's from the community, and I wouldn't blame it on any religion. It is the culture. Okay, all religions teach us to be respectful of each other, especially more so in a marriage. But we do understand that there are unfortunate people who have misunderstandings about the role of a woman or the role of a man. So maybe we need to go to the ground and look into. You see, we have a fantastic health system in Kementerian Kesihatan. From the smallest little kampung, access to at least the clinic bidan or the clinic kesihatan is not really that far off. And I'm not talking about, of course, Sabah and Sarawak has many challenges in that aspects where access is only by the river or by air. Generally in Semenanjung, there is always access. So that awareness needs to go right into the kampungs. And then once the access is available, maybe we can speak more on getting them to get the treatment faster. Tertiary centers all have their own challenges. It doesn't mean that I work in a private hospital, all is dandy. Patients are also limited by their insurance policies, and also when it comes to promises made when the agreements were signed. Nowadays we hear about insurance policies where they agree to cover reconstructive procedures for women who need to have mastectomies. Yes, they say, fine, it is covered, but then when the forms are signed, there's many T&Cs that are included. Outpatient medication, which is what most hormonal treatment is, because they are in the form of tablets. So some insurance companies do not cover outpatient medication. Now, we know that endocrine treatment, the hormonal treatment, some are recommended between 5 to 10 years, minimum about 5 years. So these medications in the original format is quite expensive. It can reach 700 to 800 ringgit a month. However, we are lucky, we have a lot of generic forms. So, but a lot of times it's not covered. Also, when it comes to early detection of breast cancer, the ductal carcinoma in situ, DCIS, a lot of policies still do not cover, whereas DCIS, these patients do need, in some cases, radiotherapy and do need hormonal treatment in some cases. So that's another thing that we need to get discussions going with the insurance companies as well. That's another thing that we need to look at. Whereas I think that's about it. Our community, our culture, and the connections, connecting the dots, you know, once you discover something, okay, what does this person need next? And these gaps, when we deal with them, we can improve on survival. Right now, stage 1, 78%, it's not good enough. Not good enough, stage 1. We should reach almost 100% for stage 1 management of breast cancer.
Thank you, Dr. Azlina. I will now pass the floor to Julia. We do have a few questions from our audience. Julia, the floor is yours.
Thank you so much, Dr. Juwita, and thank you so much to all our esteemed panelists for speaking so eloquently on this topic so far. So I'll just get straight into it, and I think we have a few unanswered questions, and I'll just field them directly towards who I think might be best placed to answer these questions. So for the first question, I would like to direct this towards Dr. Santari, if possible. So it says, it seems unlikely that the government will consider a proposal where there is increased funding for the treatment of one cancer, even if it is the most common cancer in Malaysia. Can the panel and authors of the report comment on whether the recommendation should be more general on access to treatment for all cancers, not just breast cancer? Yeah, Dr. Santari.
Thanks, Julia. That's a difficult question in terms of the complexity of the question. That yes, when you talk about equity, yes, it should be all cancers should be treated equally. Having said that, though, breast cancer is one of the most common, is the most common cancer. And it is the cancer that we can actually do, next to cervical cancer, I think it is the cancer that we can actually do the most on all the different pathways. When we talk about screening, early detection, and treatment options out there, it's got the most expansive within all cancers. So therefore, you know, if we are, and we are, unfortunately, the reality is that we're living in a world where there are limited resources. And in a world of limited resources, we need to prioritize. And taking that as my basis, I would say that I would prioritize on breast cancer. Because we can make the most impact in the shortest period of time.
Thank you so much for that answer to what I agree is also a very complex question. I hope that this has been answered by the person who asked the question. I think just in respect of time, if we could move on to the next question. So I would like to field the next question we've got to Dr. Azlina, just because this is something that you have touched on briefly, like in what you've been saying. What should the most urgent priority that the government must address be? Should it be financial barriers, geographical barriers, or cultural barriers? So this is asked by Sophia Zahari.
Thank you, Julia. I feel that the geographical barrier is one of the most important things. With the cultural barriers, you probably need 2 or 3 generations to change people. You know, like I said, you need to go to the ground level to have more talks, more interaction among those who are able to talk, and not necessarily doctors or nurses. We can have survivors, advocates to speak to from their own experience, because sometimes I get it. Patients may trust breast cancer survivors more, the survivors of cancer, rather than medical staff. So we need to get them roped in. With geographical barriers, we need to try and get places where, I shall say this, and I've been repeating myself all the time. Pahang is the largest state in Peninsular Malaysia, okay? Pahang does not have radiotherapy services at all, whether in public or in government. Please correct me, Dr. Zakia, if I'm wrong. So any patient in Pahang who has small, who have small breast cancers, if they do not agree to have radiotherapy services, they need to have total mastectomy. They can't have lumpectomies, because with lumpectomies, you need radiotherapy services. And radiotherapy services are not only used for treatment of breast cancer, is used for treatment for colorectal cancers, cervical cancers, all across the board. Okay, it's just that in breast cancer treatment, we utilize a whole armamentarium of surgical. You need operating theaters, you need the specialist trained to do breast. And I must say, there are more general surgeons in Malaysia than breast surgeons. And that's how I trained to be a breast surgeon. You have to be trained to be a general surgeon first, then you subspecialize. So in the curriculum for the Masters of General Surgery, we are taught how to manage breast cancer. So you can't have, you know, we need to look at what's available out there. Then, apart from the services that are needed for breast cancer, you need chemotherapy services for a lot of other cancers, the blood cancers, the solid organ cancers. So it's just that the availability of what's needed for breast cancer can be used for other cancers as well. We're just not focusing purely on breast cancer. It is the highest number of cancer all over the world. And if we don't get the setup, the structure organized for radiotherapy, you can't have an oncologist coming to have only part of the treatment available for him or her to carry out his or her services. So that is the idea of the geographical barrier. So, for example, patients in Pahang, either they come to Klang Valley or they have to go to Kota Baru. Okay, but right now I'm not so sure, Dr. Zakia, whether there's an oncologist in Kota Baru, because I knew the last one just left for private. Now there are? Okay. Yeah. So for patients in Pahang, either they have to go north or have to go to Klang Valley. So they have visiting services or oncologists from IKN, but you know, it's better to have a resident oncologist to be there all the time. Okay, so the geographical barrier, the cultural barrier, financial barrier is a bit difficult, you see, and it's related to the services that's available. You need money to set up things. You don't have money, we cannot talk. So this is all related. Okay, thanks, Julia.
Thank you so much for answering that question, Dr. Azlina. I agree that they all seem to be very interrelated when you put it that way, and the geographical barrier being something that maybe we don't talk about enough as well. So I would like to, well, this next question is actually directed specifically towards Dr. Zakia. So can Dr. Zakia please share more details on breast cancer prevention efforts and strategies by MOH? bearing in mind the fact that one of the main risk factors for this disease is genetic profiles. Over to you, Dr. Zakia.
So thank you, Julia. So basically, we have started our breast cancer awareness and also early detection program since 1995. So in the early 1995, we have started in terms of making them aware on how to detect the sign and symptom by having these kinds of breast self-awareness. So that so our awareness campaign or our awareness strategy is more on the how to do the breast self-examination for the women. Okay, so that is actually the first initiative in 1995. So apart from that, we have our routine, the healthy lifestyle campaign. So we have like stop smoking, healthy exercise, regular exercise, and so on and so forth. So we are also continuously engaging that elements as well, because we know that not only the sign and symptom, but they must actually trying to avoid all those sorts of the risk factors like obesity, smoking, and everything. So we just like do the continuations or the extensions of this healthy lifestyle campaign to put the elements of the breast self-examination as the awareness tool for the women's. And in 2009, so this initiative has been emphasized, whereby we introduced the clinical breast examination. So the clinical breast examination is actually the tool that is actually done by our healthcare providers in clinic kesihatan, in our primary care setup. So all all our nurses or even the doctors will ask if there is any kinds of problems, or if they want to be examined for the clinical breast examination. So our nurses will do the examination, and if any kinds of sign or symptom, they will refer them straight away to the SOPD in the public hospital. And in 2012, so we have been actually again improve the early detection and screening program by integrating the screening elements. Okay, we in our health clinic, in our clinic kesihatan, we are the entry point to those who want to do the mammogram. So meaning to say that we screen all the potentials, the high risk women, and then we document them, and if necessary, we will do the referral for the mammogram services in our public hospital. But we are actually asking them if, let's say, they have any options. If they feel that the government hospital will take times, maybe in 3 months or 4 months duration, so they can actually opt for anywhere. So like in doing the services or mammogram services in LPPKN and private hospital, universities, and everywhere. So basically, these are all the initiative effort that has been done by the Kementerian Kesihatan Malaysia.
Thank you so much, Dr. Zakia. That was a very comprehensive way of stating everything that in response to this question. So I think for our final question to the panel, I would like to just raise this last one. I think maybe just direct it to anybody on the panel who feels best equipped to answer this or most inclined to answer this. So the panelists mentioned on collaborations and public-private linkage. Could I ask on which patient pathway do the panelists foresee a potential collaboration area? Taking costs into consideration, would it be potential for public-private collaborations in surgery or radiotherapy treatment modalities? I know that this actually does perhaps link on to something Dr. Azlina was saying just now as well. So perhaps you can go first, Dr. Azlina, and then we can see who else has any input on this.
I think in terms of collaborating, there is already some sort of collaboration whenever certain things don't work. For example, if machines break down at a nearby public hospital, they already have agreements set up with nearby private hospitals to send patients, example, for CT scans or MRIs, if the machines break down and may take some time to get it repaired. In terms of, I feel that if the workload of a certain department, for example, for mammograms or ultrasounds or CT scans or biopsies, it may take longer than a week or 2 weeks. I think there is room for some sort of collaboration where patients can be asked to go to private setups where the imaging can be performed, or even to an NGO like National Cancer Society, where Dr. Santri is. They are very close by to the Kuala Lumpur hospital, just within walking distance actually. So they do free mammograms, they do subsidized mammograms and ultrasounds, they even do biopsies. Yes, I have been sent patients referred to me after biopsies done in National Cancer Society. So there is this sort of minimal collaboration going on. We could step up on it. The thing is, we are not, inverted commas, talking to each other. If your workload is very high, we need to find a way to, I don't like to use the word shuttle, but I don't know what other word to use it, but it is a way of reducing workload. See, during the pandemic, we were more than happy in private to receive patients to have their surgeries done. We knew that certain hospitals would close their operating theaters, but it took a long time to organize. You know, that's all this nitty-gritty bureaucracy. I'll just say bureaucracy. You know, we need to reduce all this to make it better for our own rakyat. You see, they're all Malaysians. You know, we are trying to make it better for Malaysians. We're not talking about, you know, foreigners. We're trying to make it better for our people. So if the workload is too much, and the idea of setting up a committee, okay, go through the committee, or maybe set up something like telemedicine. Now, you know, we go on Zoom talks like anything now. We didn't think about it last time. Oh, I get nervous looking in front of the computer and all that. Now we don't think much about it. It is available. You know, all our mobile phones are set up. You know, we have the Zoom app. We can always collaborate with each other. It's just a matter of trying to organize it and seeing who's in charge. Let's rope in people who would buy the idea, or people who would actually be motivated to start, to make it last. Because, you know, in Malaysia, maintaining things are not one of our better capabilities. Maintenance of certain systems or committees that would ensure that these things run for more than 5 years. And we don't want something to stop after each government changes. Yeah. Thank you.
I'll follow on from Azlina there. I think, yes, her last comment is pertinent. When it comes to collaborations, the National Cancer Society, all we do is collaboration. You know, I will state straight out that every single one of our services we cannot provide if we do not collaborate with someone else, with another organization, be it government, private, individuals, other NGOs, etc., etc. Collaboration is the key in terms of our success. Okay. But collaboration is based also on mutual trust and respect, and transparency, in terms of there has to be communication. There has to be, as Lena said, we need to talk to each other. We need to really understand where our expertise is, what we can do, what we can offer, and be open about it. And with that, I think we can really elevate what is going on in Malaysia, especially with breast care and also other cancers in the country. When we talk about private and public partnerships, as Lena alluded at the end, is that it can't be just one political cycle. The government has to show that it is committed to healthcare. I think that's incredibly important, and being committed to healthcare is not, and Dr. Zakia knows this, and I do feel for those in MOH, because you're living from one cycle to another. You're living from this budget to the next budget to see what you can do. We can't organize healthcare like that. If we organize healthcare like that, we're going to be what the UK is now, where everyone is on strike, where you don't have enough resources, etc., etc. We need consistent commitment to healthcare, which is over a 5-year plan, a 10-year plan, a 20-year plan, where we want to be in 50 years. And the government, and I'm not talking MOH, I'm talking about government, has to be clear that they are committed to that. And only then can MOH do its job. And only then will the private sector with corporations, etc., that when they see that commitment from government, they are willing to put their money into healthcare as well. They are willing to collaborate. Because they see the commitment, they see the dedication, they see the transparency and the clarity in the direction in which we want to go, and they will want to be part of it. And that's how collaboration works.
Thank you so much, Dr. Santari. I think that sustainability is a key word here, and that is really important. I mean, just before we close the session, Dr. Zakia, do you have anything to add to this question?
So I think basically both panelists have already mentioned it very concisely. So I think in terms of coordination and collaboration, we as Ministry of Health is concerned, we are actually pros on that concept. Okay, even me myself, I'm looking at the potential of having a good and a very high quality of services by having these kinds of good coordination and good collaboration. It's not only one of a strategy, but as has been mentioned, we need actually to make it sustainability. And I think that while waiting for the healthcare reform, I'm not so sure whether it's going to be in this coming 5 years or whatever years, but I think we can actually do kinds of reform in our breast cancer control programs. And I hope that by starting having these kinds of engagement and ideas and looking at the report, it will be like one of the strategy, one of the reference for me to discuss it more further and what to do next. So I believe that we need actually to strategize. We need actually to get this collaboration effectively and sustain by having a good concept and also a good strategy and policy plan. And it's good when you are highlighting that the plan of action. So we are actually thinking on that concept as well. Okay, we are actually taking on making a short-term and also long-term plan of action specifically for breast cancer. So I hope that these kinds of ideas, I'm hoping that we'll try to do at least by starting from this year, the initiations of the ideas, the discussions, because you know that to revamp everything, to transform everything takes time. So at least the initiations of the idea, the concept, we can actually try to make it. And yeah, that is actually one of my commitments for our breast cancer control program in Malaysia. Thank you.
Thank you all. I will treat that last question as also the last message from everyone here. In the interest of time, we've gone over time, but yes, thank you so much to the panelists and thank you so much to the presenters for a wonderful presentation as well as an in-depth examination of the issues and as well as the policy recommendation. So again, we here at Ideas, we would love to continue this very important work on access to healthcare, and we hope we do have the support from the stakeholders on the ground and also practitioners and activists as well. So before we leave, can I ask all of the presenters and also the panelists to turn on their cameras for a photo, a group photo, please? Zudi, could you take a photo, please, and signal us?
Okay. Okay, we are taking the picture now. In 1, 2, 3. One more. 1, 2, 3. Okay, one more. 1, 2, 3. Okay, thank you.
Thank you, everyone, and have a great Friday and great weekend. See you
Thank
soon.
you.
Thank you.
Thank you,
Bye.
Ideas. Bye.
Thank you. Okay, thank you so much, Dr. Azlina, Dr.